My name is Michael Schwartz. I'm a urologist with Northwell Health. I work at the Smith Institute for Urology. And today I'm going to be speaking with you guys a little bit about prostate cancer screening and what has changed over time, really a contemporary view of that topic. So to get started, just to cover a few basics about why we do what we do with prostate cancer screening. We do cancer screening in general to try to find diseases early, to get them at a point where they're much more treatable and curable than they may be later on. And prostate cancer is quite common. It's the most common cancer for men outside of skin cancer. And annually in the US, we see about 250,000 cases. And there are about 34,000 men who die of prostate cancer each year. And lifetime risk of prostate cancer is pretty high. It's about 1 out of every 8 men. So common cancers are the ones that we do care to screen for, and this is definitely one of them. So in general, prostate cancer does not cause symptoms until it is very progressed, it's advanced, and maybe metastatic already. So we don't really want to wait until there's symptoms to know about it, because at that point, there's really not much chance to cure it. Where we catch it early, we have a much better chance of handling it before it escapes and when it's curable. And early detection of prostate cancer does allow for the disease to be discovered at that time point. So historically, prostate cancer screening has really been about a digital rectal exam, which is basically your doctor putting a finger in the rectum to feel the surface of the prostate. And what they're doing is feeling for a bump or a nodule or some asymmetry, something that could clue somebody into the fact that there may be something abnormal going on here. And then PSA came into the mix in the late 1980s, which is a blood test, which I'll cover in a minute, a little bit more detail. But traditionally, if either or both of these things were abnormal, a biopsy would be performed. But nowadays, we use much more information than this when we're making decisions about does or does not somebody need a prostate biopsy. So PSA, just to let everybody know what this is, if you're not familiar, it stands for prostate-specific antigen. It's a protein that is made by the prostate and only by the prostate. And this protein can be detected in the bloodstream because a little bit of it gets out into the bloodstream from the prostate gland. So when this level is elevated, it's not necessarily true that there's cancer because there are other disease processes that can also make the PSA go up. For example, most commonly, it is BPH, or benign prostatic hyperplasia. In other words, it's an enlarged prostate. So you may expect a bigger prostate may have more PSA. And similarly, if there's something else that kind of disrupts the normal architecture of the prostate, the normal way things are flowing through it, the normal structure, like inflammation or infection, that could also cause the PSA to go high. And then, of course, prostate cancer is the last, but really the prime reason to do the PSA test. So is prostate cancer screening recommended? There's some controversy about that, and I'll get to that in a moment too. But the short answer is yes. The American Urological Association publishes guidelines, as do many other medical societies. And the recommendations from that group, which is a national group here in the US, is that men really benefit most from this screening at ages 55 to 69. Now, a lot of men choose to get screened earlier, either from their own personal choice or if they happen to be someone who's at increased risk for prostate cancer. That could mean an African-American patient or someone who has a strong family history of prostate cancer, especially if someone has a family member who's been diagnosed early in life with prostate cancer. In general, screening for prostate cancer is not recommended above age 70. Although there are some exceptions to this. If you happen to be a particularly healthy 70-plus-year-old person, there may still be benefit for you. But if you have a life expectancy that's considered to be under 10 years, it is recommended against screening. Now, the PSA test is a bit controversial. Now, and the reason for this is that the United States Preventative Services Task Force came out a few years ago commenting on prostate cancer screening, and they recommended against it across the board. They stated that there was not enough evidence to support its use. So that, of course, created a lot of controversy. But the relevant questions are real. So does screening actually reduce the number of deaths from prostate cancer? That's one primary goal of screening. The other question, can diagnosis and treatment do more harm than good? It's another relevant question. We don't want the treatments of a disease to be worse than the disease. And also, overdiagnosis of low-risk prostate cancers. Most of these don't need treatment, but a lot of these were getting treated in the US. So that led to these recommendations being made. Now, that being said, there was a lot of pushback from patients and physicians. A lot of patients had benefited from prostate cancer screening and treatment. And ultimately, the US Preventative Services Task Force came out with revised recommendations. And this came to pass because the data that they used to make their recommendations actually turned out to be pretty flawed data. There wasn't a lot of good studies that they used in order to come to their conclusions. And their recommendations are now that patients and physicians need to use a shared decision-making process to decide if prostate cancer screening is right for a patient. Now, the bottom line, though, is that prostate cancer screening does work. There are some randomized controlled studies, which are the highest level of evidence that we have to show something can work like this, to show that patients who are screened develop less metastatic prostate cancer, and that's when it really can become symptomatic. And also, there are less deaths from prostate cancer. Now, the caveat to that is that because prostate cancer in general is slow growing, it takes a long time to see those benefits, meaning a lot of follow-up time has to pass to determine if screening is helpful. And some prostate cancers are very aggressive, so they may need less time. But overall, the whole group of patients with prostate cancer, you need quite a bit of follow-up. So beyond 10 and 15 years, that's when that benefit starts to really show itself in a very clear way. But this is also why prostate cancer screening is not recommended for patients who are above 70 or 75, let's say, because they may not have a life expectancy to warrant the screening because the benefit may not be there. So screening these days really is much different than it used to be. We have really a lot of new tools to help us with patient selection for who needs to take steps beyond just getting a PSA blood test. So in other words, who needs to go on to getting a biopsy of their prostate? One of our most important tools these days is imaging. The MRIs that we use to image patients' prostates these days have really come a huge way as far as the quality and detail we get from imaging. And it is very helpful in detecting prostate cancer, especially ones that may need treatment. MRI is less good at finding the cancers that are the very low risk cancers, and these are often ones that we don't treat anyway. So it's kind of a good thing that they may not find the least aggressive of the disease. So that's one tool. And then we also use a tool called PSA density. So in other words, PSA density means the PSA level that a person has divided by the size of their prostate. So that puts the PSA number in the context of how big the prostate is. And you may remember earlier I mentioned that the prostate size in particular can drive the PSA higher. So knowing that information is much more helpful than just the PSA number alone. And that can be very informative to make recommendations to a patient about a biopsy. And then last, there is new blood work and different tests available out there commercially that is meant to help risk stratify men. So we categorize men into different groups depending on some test results. One common one is the 4K score. Another one is called the Prostate Health Index. And these can basically provide patients with a percentage risk of how likely it is that they may have a prostate cancer that we would call clinically significant. So results of the new screening methods that we use these days are that there are many fewer biopsies in patients who don't need them. So the MRI in particular has been very helpful to help a lot of men avoid a biopsy who would otherwise years ago be going for a biopsy simply because they had a PSA elevation. Now we know differently how to interpret things in a much more accurate way. The MRIs that we use also are much more beneficial as far as the accuracy of the diagnosis. So what we get from an MRI is if there's a particular area within the prostate that appears to be concerning or suspicious, we know we can go biopsy that area, and that area might have been missed on what would be called a standard template biopsy of the prostate, meaning one that's done without imaging. It's more blind, so you don't necessarily sample a most concerning area. The MRI is helpful to do that. And we also get much more detail from an MRI in terms of treatment decisions. It gives us more staging information. So the question of did the cancer remain contained in the prostate or spread outside, the MRI gives us a good initial look at that question. So the story of cancer here, prostate cancer here at Northwell, is, I think, pretty interesting, and one to me that's really one of the most exciting parts of my job, because we've really taken what initially began as a quality project to help improve reducing infection rate into a whole new realm of how we diagnose and then ultimately treat cancer. So in the past, we had used transrectal biopsy. So that means when we did a biopsy of the prostate, we had an ultrasound probe inside of a man's rectum, and we would use that imaging to guide a needle into the prostate to take samples, and then that would be analyzed for possible cancer. So it's an easy to perform procedure and reliable in establishing diagnosis for the most part, but it does place patients at risk for infection. So for example, patients would be treated for several days with antibiotics before, during, and after a biopsy. And even despite those measures, patients would still get an infection with sepsis somewhere between 3 and 7% of the time. And that's not only here at this institution, that's a national kind of number. And rarely somebody could even die of a biopsy, which is, of course, a terrible outcome. So we looked at this problem and said, how can we do things better? So we did a quality project with our residents here who are training with us to be urologists of the future. And we asked, how do we reduce the risk of sepsis? So we first changed the antibiotics around to see if that would help. We did cultures of a patient's rectum in advance to see if we could specifically tailor antibiotics to that person. We did enemas with fleet enema and betadine to help clean the rectum. And we also used all disposable instruments to do the biopsy, but nothing worked. This was the problem. So we looked at this and said that we looked back and saw the sepsis rates really did not change, or they sometimes even got a little bit worse with one of these measures. So we took the step of trying something different. This quote, I think, is very relevant to this and many other issues too, but the secret of change is to focus all of your energy, not on fighting the old, but on building the new. And we took this to make a new process. We avoided the rectum altogether. We started doing transperineal biopsy here in August of 2018. And the perineum, that's the part of the body that's located on a man between the scrotum and the anus. It's that patch of skin where you kind of sit on a bicycle seat. And we started doing biopsies, passing a needle through that area. And we also incorporated the MRI technique of doing biopsies with targeting also through the perineum that same year. And I was one of the leaders of that initiative, and I trained many of our faculty members who do biopsies to do it in this way. And we started prohibiting doing rectal biopsies at all. And what do we see? We saw the sepsis just disappear, which we're just extremely proud of. And it just makes it a much safer procedure for patients. We don't need antibiotics around one of these biopsies either, which makes the preparation easier and reduces the side effect. And in retrospect, when we look back at doing transrectal biopsies, it's almost hard to believe that we could expect anything else but some infections. You know, we're going through a dirty area, and it's inevitable, I think, that we would see infections. But this new approach really was a game changer. So we do this as an office-based procedure. We take local anesthesia to do it. That means we inject the area with lidocaine, and it takes about 10 or 15 minutes to do it. As I mentioned, we don't use antibiotics, which is wonderful. We see diagnostic yield of a biopsy either the same or even better than a transrectal biopsy. We also see patients are actually more comfortable with this new technique. We can get a much more reliable block with the local anesthesia than we could with our older method, and patients like this better. It's easily incorporated into our office routine. We do these every day here. And overall, in a Northwell system, we do a lot of biopsies. Remember, we have many hospitals across the New York area and in lower Connecticut. And overall, we do about 1,900 biopsies each year. And so if you took the number of patients that would be infected if we were doing transrectal biopsies, that would have resulted in anywhere between 57 and 133 patients being hospitalized with sepsis. So again, we're not seeing that anymore. That's a wonderful and game-changing, change in our practice. So despite the obvious benefits, the rectal biopsies remain generally the standard of care for most urologists in New York and nationally. And it's really too bad that this is true, but there's a lot of barriers to people adopting this. I think mostly a cultural thing, but also there's a perception out there amongst urology physicians that if you do a biopsy with this new method, that you might require general anesthesia. So you don't, and we've proven that over and over again. There's also some financial barriers. You need to have different ultrasound equipment to do this than you might otherwise, and that can be a barrier for people adopting it. And it takes time to both train as a urologist to do these. It's a little bit of a different skill set, and they feel like it might interrupt their normal work hour or work flow in their office. And transrectal biopsy just in general is still widely accepted. And we here are advocates that we really should get away from doing those to clear out these infections that keep coming up over and over again. But nonetheless, this is still the accepted, what is considered, quote, standard of care. So we have to get out with the old and in with the new. I wanted to show some images here to show how we do things these days. So what we're looking at here is an MRI of the prostate. So I'm going to use an arrow, I hope, to outline. This is the prostate here. Excuse me, let me come back to that. This is the image of the prostate here. I'm circling the prostate gland. At the bottom down here is a patient's rectum, and above it, this is a little cut of the bladder. And then on either side over here is the bones of the hips. And you can see there's an arrow pointing here to this dark spot in the prostate. So this is a prostate cancer. This is how one might appear on an MRI. And you can see that the prostate's pretty big. And if you decided to biopsy without knowing where this is, you might miss it. So this is just an example of how we use MRI to help us detect the cancer when one is present. And this is a picture just to show you the technology we're using these days, really the state-of-the-art stuff for how to do biopsies. So this is a picture of someone who had a biopsy done with the help of an MRI and ultrasound. And the pictures we're looking at here are this top image in the top left. This is an ultrasound image of the prostate, which is circled in a purple outline. And these other images in the top right and the bottom left, these are from the MRI. So what we do is that we use the MRI images that we've obtained prior to doing a biopsy, and we do an ultrasound of the prostate during the procedure in real time, and we fuse those images together. This is called a fusion biopsy for that reason. So this computer software, in other words, links up the MRI with the ultrasound, and it helps us to take a spot from an MRI and move it right over to the ultrasound so that we know where to sample from. So that's an example of how we do biopsies. And this is really the new paradigm. This is what is generally now considered to be the biopsy type that gives us the highest rate of detecting an issue when it's there. And guidelines now from the AUA, the national organization I mentioned earlier, recommends doing an MRI before you do a biopsy. The other advantage that I mentioned of MRI is that this can avoid unnecessary biopsies for men who may not need them. So if somebody has a clean MRI and they have what we talked about earlier, a PSA density that is low, that means the prostate may be big, even though the PSA is only mildly elevated. Those patients really don't need to be undergoing biopsies, and we recommend against biopsies in most of those situations. So this helps us significantly to improve on our selection for who goes to need a biopsy of their prostate. And that also translates into a much better cancer detection rate because we're not biopsying the people who don't need it. It calls out the patients who would just normally have a negative biopsy. And we're unique in the volume and the quality of the diagnostics that we provide here. We are very proud of our biopsy and screening program. So I just wanted to touch base briefly before I finish up on a couple of the new and fairly novel things that we're doing here that have basically translated from our perineal biopsy program. So that is focal therapy. So what we've basically done is that we've taken a skill set of biopsies, which means placing needles in a very accurate way into the prostate and thinking about using that method of treating cancer specifically. So not only putting a needle in to make a diagnosis, but now to treat. If we can see a cancer, a spot on an MRI, and we can localize it to that part of the prostate, a patient can be a candidate to get focal therapy. And what that means in just layman's terms is that we use energy that's either usually heat or cold to freeze or heat up the part of the prostate where the cancer is located. And that can kill that prostate tissue. And it does not affect the rest of the prostate. So this can be a wonderful thing for patients. And we have a few different methods here that we have used and some upcoming trials that we're running as for new methods that are coming into the mix. So focal cryotherapy is one. That means freezing of the prostate. We're just now finishing up a clinical trial using what's called nanoparticle-directed laser ablation. And I won't get into the details, but basically it's using the light from laser to heat a part of the prostate where there's cancer. And we use MRI to target, just like with biopsy. And then an upcoming method, which is kind of the latest trial we're going to be opening up soon, is something called irreversible electroporation, which is using electric current, more or less, to treat focal places within the prostate where there's cancer. And this is an example, and I won't show you every detail here, but I wanted to just briefly show everyone what focal therapy can mean. So focus for a moment on this top image in the top left. Again, this is an MRI. We're looking at the prostate with a green outline around it. And that little purple circle at the top, really the inner green circle inside the purple, that's the cancer. So you can see it's really just a tiny part of the prostate, but this one was aggressive and we needed to treat it when it was early. The purple is meant to be what's a treatment zone. So in other words, we treat this, in this case, this was cryotherapy, freezing. We treated the tumor, but also an area around it to give us a margin. That makes sure that we treat not only the tumor, but an area around that we know we're going to get the whole thing. So this is similar to a biopsy, but we use this targeting software to help us do that. And it spares the rest of the prostate and the nearby structures like the rectum, and also some of the nerve and blood vessel structures that are important for men's erections, which are near the prostate, but well away from an area like this. Those typically don't get affected by this kind of treatment. And this is some of the targeting software. It's the same patient, but just to show some of the kind of the novel technology out there. This is the next generation of ablation software that we use. So in other words, so the way that we use to help us guide needles to the prostate to treat. And this is just showing some of the different structures that the computer can help us know exactly in space where everything is. The top left image here is that same image of the prostate. The target is that green circle, and the lighter blue circle here is where we're going to treat the patient. And this is just amazing technology, and it really helps patients to recover so much differently and quicker than men who, let's say, had surgery or radiation treatment for their prostate. So I wanted to thank everyone for their attention. Again, I'm at the Smith Institute for Urology, which is part of Northwell Health. You can reach us if anybody has questions, 516-734-8500. And my email address is here, mschwartz5@northwell.edu. Again, thank you so much for joining me for this. It's really been a pleasure to present some of our latest and greatest as far as our screening, diagnostics, and treatments. And we hope you enjoyed it. Thank you.